I'm Ross Coppell. I'm the second speaker. And of course, I have the advantage of having seen Dr. Sheik's excellent presentation, and I can respond to some parts of it. But I know, of course, that my colleagues Dean Sittig and Guy Mattern will respond to the earlier speakers. So, following Dr. Sheik's example, a word about myself. My PhD is in sociology, concentrated on work in the professions, on research methods, on statistics, usually on the role of technology. For the past 23 years, I've been teaching at the University of Pennsylvania, usually research methods, sociology of medicine, statistics, and of course, conducting a lot of research. Before that, I've worked at econometrics, think tanks, policy agencies, other schools. I'm also a PI and affiliate faculty member at Penn's Med School and at the Leonard David Institute for Healthcare Economics. I'm a senior fellow. That's part of the Wharton School. At Harvard, I've been an evaluator of the SMART project, and I'm a PI and senior investigator on several studies. I've been researching HIT for about 35 years, most intently, almost entirely for the past 14 years. My work usually combines analysis of computer logs, observation and shadowing of users, surveys, focus groups, attending FMEA and M&M meetings, and innumerable interviews with clinicians, IT personnel, vendors, and hospital leaders. Now to the motion. Health information technology is already improving healthcare safety, and current regulation is around it. Well, that's really two items. One, that HIT is already improving healthcare safety, and two, that the regulation is sufficient. So let's look at the first one. I sort of weakly agree that HIT is improving healthcare safety, but with so many reservations. Few would go back to paper, and paper costs pennies versus implementing EHRs in American hospitals and medical practices, which will cost $3 trillion, and it incorporates the greatest advancements of computers and human effort. So can we be satisfied with HIT that lacks many of the desired functions, is poorly integrated into workflow, is not interoperable or can share data standards, has usability that's 20 years behind any other industry, and is not focused on safety until very recently? Note my list. It's exactly the same list that Dr. Sheik notes as the problems with HIT. So we agree, and Dr. Sheik's honesty is commendable. In the US, such honesty would be close to treasonable. In fact, two recent studies found that 70% of US physicians said EHRs on balance are not worth it. Most EHRs are said to lack usability, lack interoperability, interfere with doctor-patient relations, not focus on safety, and add extra and meaningless work. EHRs are the leading cause of frustration. And the US Senate 3 days ago said, we must help make the failed promise of electronic health records something that physicians and providers look forward to instead of something they endure. Why these problems? Let's look first at data standards and interoperability. Without data standards, interoperability is almost impossible. Lack of data standards not only prevents interoperability, it means we can't combine the oceans of data that would jumpstart medical science exponentially. We have, without data standards, blinded ourselves to our own information. Lack of standards also ensures vendors can continue with their individual data systems, data structures, which of course benefits vendors via sales of entire suites of products that only link with their own systems. The buyer is locked in. Obviously, lack of interoperability affects patient safety and cost. Tests must often be redone. Information is lost. Doctors treat without that information. Delays are pandemic, plus, of course, the pain and the excess radiation of repeated tests. Then there's usability in patient safety. The link should be obvious, but until recently, industry insisted usability was entirely subjective and theoretic, depended only on the user's skill, and largely unmeasurable. Only very recently, under constant pressure, has EHR industry embraced the call for, but alas not the reality of, usability. EHR usability is still primitive. It's often lost in, information is often lost in vast deserts of poorly displayed information. Clinicians must click through 15 screens and scroll for minutes to find data that should be contiguous. Need I argue that patient safety is affected by poor usability and efficiency? Now, Dr. Sheik's list of problems also included limited functionality. Let's look at that. Vendors largely created the legislation and subsidies of high tech. Many functions were promised, but then drastically scaled back when the requirements for certification were made real. Vendors demanded fewer functions for certification, supposedly on behalf of their clients, claiming that it was the providers who lacked the skill or capability to meet those requirements. But let's be real. In almost all cases, the reason was that their software was incapable or inflexible and could not meet the requirements the vendors themselves claimed they had achieved 15 years ago. This is blaming the victims. Most directly here, safety was not addressed until the last year or two. Look at certification requirements. Safety has often been absent. It's only been added recently. I could go on here, but let me address two last comments by Dr. Sheik. He says that while there's no good evidence of improved safety, there's no good evidence of overwhelming harm from HIT. Well, I commend him for acknowledging the lack of evidence of improved patient safety. This stands in dramatic contrast to the US position, where even raising the question of safety is heretical, because more HIT was assumed ipso facto to provide more safety. Scholars who questioned that syllogism, more HIT equals more safety, were vilified. Government and industry stories and articles focused entirely on the benefits, or almost entirely, which of course is no way to learn or improve. The ONC was concerned about encouraging sales, and acknowledging problems is counterproductive to that aim. We'll see that that's a short-term optimization. Sometimes enthusiasts took a fallback position that HIT's benefits are overwhelming but just hard to prove. This position has a patina of intellectual honesty, although it's unconvincing, and it raises another point: why it's so hard to document the cause harm by HIT. Let's look at that for a second. The major cause of medical errors is medication ordering errors, but they are largely invisible because patients are old, sick, suffering from 3 to 5 comorbidities, and are on 13 or 14 other medications. We can't see our errors. Perhaps more important, if physicians or others realize they've ordered the wrong drug, they cancel them very quickly. And it's by definition only the unknown errors that are most likely to cause harm, which is hard to see. So most HIT-related prescribing errors are usually unknown and largely unknowable. So, in ending this section of the response, I agree that HITs may improve patient safety, but it's HIT that's frustrating, non-interoperable, poorly designed, user-hostile, and non-integrated, and safety was assumed. Are we satisfied with that lower bar? In any event, I have to move to the second. Current regulation around HIT is sufficient. Look, no one wants onerous regulation, but many use the fear of regulation as an excuse to be sloppy, to engage in protective or non-competitive actions. Remember, we all love and need good regulation, like stopping at red lights or driving on the correct side of the road. Well, there are two kinds of regulation here. The first, FDA, which they want to cut back further, and the second, meaningful use in CMS. Let's look at the FDA first. In 1997, with the urging of industry and friends, the FDA agreed not to regulate EHRs. The industry said that regulation would retard innovation. Now the industry has another push for even less FDA regulation of EHRs. I don't know what less than zero is, but they want it. And once again, the first rationale is the same. Don't retard innovation. We've had no FDA regulation of EHRs by the FDA for 18 years. Where's the innovation? And the industry has added a new twist. We don't need regulation because EHRs are low risk. What is low risk about EHRs? These systems collect and display lab reports, histories, medications, allergies, tests, vital statistics. We use them to order drugs, treatments, tests, guide colleagues. They have impenetrable legacy code and tables. They interact with up to 400 other IT systems within and without their institutions, often with different data protocols. They are among the most complex software systems ever built, and they hold the lives of humans in their grasp. How can that be low risk? The software solves, in my opinion, some safety problems. It does, but it also facilitates many others. And I fear that without FDA oversight, EHRs will continue to ignore safety issues. But now let's look at the other form of regulation, meaningful use in CMS. Let's start with certification, that's supposedly safety valve. Vendors secured the best of both worlds for themselves. Providers are required to buy certified HIT systems to receive the subsidies and incentives. But certification is largely a sham. Almost every vendor's product is passed. There are no time requirements, and it's an open book test. Tasks that could take, or usually take, a few seconds for a doctor can take up to 8 hours in the certification process, but still pass. And safety has never been a part of the certification process. This whole certification is a negotiated bureaucratic hurdle to surmount. Note that about 96% of EHRs have been attested to by only one medical practice. Now we come to the existing and the forthcoming 600 pages of new MU rules and regulations. Were they and are they sufficient to ensure safety, as per the motion? My answer is no. But they are a hodgepodge of hated box checking, weaselly compromises with vendors on functionality, ignoring safety and sidestepping usability issues. We overwhelmingly often are obliged to just check off meaningless proxy measures that enrage physicians. They encourage workarounds, impede efficiencies, detract from doctor-patient relationships. Again, little about safety and only lip service about usability. 70% of US doctors said they were not worth it on balance. So let me offer 4 regulatory steps that could improve safety dramatically. It's been 8 years since Dave Creeder and I exposed the non-disclosure clause and hold harmless clause in vendor contracts. 2 IOM reports and AMIA's safety board of directors called those clauses unethical. But the user-friendly regulators have not said a word, and they continue to this day. So my first recommendation is that non-disclosure clauses that prevent doctors and others from showing screenshots of vendor software that may lead to patient harm, those should be removed. It's absolutely a danger to patient safety. It is not finding and fixing problems a spur to innovation. Second, the hold harmless clause puts all of the responsibility for errors within the software entirely on clinicians and medical institutions, absolving vendors for any problems and certainly not motivating them to address the problems. Third, usability is essential to patient safety, but has been denied, ignored, and circumvented. NIST's role was to be essential here, as outlined in HITECH, but it's been largely silenced. And last, we need data standards to ensure interoperability. The two workarounds that have been suggested, APIs turn out to be widely varying in quality, a topic that's not even addressed. They're just presented as a silver bullet. And CCDAs are both too limited in the number of variables and also have several weaknesses. See John D'Amour's recent research. In sum, we have policy that is based on faith that more HIT equals more patient safety. We have faith that regulation will retard innovation, even though the industry has had no FDA regulation and only friendly rulemaking since HITECH. We have products that are demonstrably user-hostile, non-interoperable, often unsafe, and anything but innovative, except in their pricing schema. So, colleagues, to the motion, is regulation sufficient? No. From the FDA, we've had none, and they are seeking less. From meaningful use, we've had little regulation that addresses safety and data standards and interoperability and usability. The ONC's 10-year vision for interoperability is about 9.5 years too long. We can't wait. Of course, we don't want stupid regulation, but absent the industry's positive action, we need regulation to encourage innovation and to improve safety. Thank you very much.